Hello, and welcome to my clinical case report. My name is Kras, and this is for Nursing 6435 Pediatrics for South University on today's date, April 5th, 2021. Today we are seeing a 7-month-old West African male who is presenting to the clinic for a well child exam. The sole source of information is from the parents, and they currently deny any complaints of illness or infection of their child. They have recently immigrated from West Africa and are at the clinic to establish care. The parents of our patient do state that his medical history is positive for abdominal pain. They further state that his only source of nutrition is goat's milk. The patient is not taking any prescription or over-the-counter medications. Family history is relevant for maternal hypertension and paternal hyperlipidemia. Family social history is relevant for the father smoking a pack a day in the home with the child. The family also recently immigrated from West Africa, as previously stated. Upon examination, the male infant appears healthy. He is a recent immigrant from West Africa. He resides at home with his mother and father. He has a recent history of abdominal pain, and his sole source of nutrition is goat's milk. For review of systems, we first look at the general constitution of the patient. There are no concerns of weight loss or gain, fever, or change in activity level. Skin, there are no history of rashes, eczema, excessive bruising, or skin lesions. For his eyes, there is no complaint of discharge or pain, excessive tearing, or itchiness. And for ears, there is no problem with hearing, ear pain, or drainage. For the nose, there are no complaints of runny nose or congestion. Mouth and throat, no inflammation of oral mucosa was noted by the parents. Cardiac, parents deny sweating, color changes with feeding, history of murmur. Respiratory, there's no history of cough, wheezing, or shortness of breath. Gastrointestinal, there's no history of abdominal pain or complaints of diarrhea, constipation, emesis, hematemesis, jaundice, or colic. Genitourinary, there are no complaints of urinary frequency, dysuria, hematuria, discharge, or polyuria. Musculoskeletal, there are no complaints of joint pain, myalgias, weakness, or injuries. Neurological, there are no complaints of developmental delays, trauma, seizure activity. Psychiatric, there are no complaints of increased fussiness, clinginess, or decreased energy levels. And then for our last review of system, hematology, lymphatics, and endo, there are no complaints of fatigue, swollen lymph nodes, bruising, bleeding, intolerance to heat or cold, increased thirst or hunger, or changes in urination. The physical exam will start off with a weight of 18.3 pounds, a height of 27.2 inches, blood pressure of 80/56, heart rate of 100, a respiratory rate of 26 breaths per minute, and a temperature of 98.6 degrees. Physical exam will begin with just a general appearance of the child. He is a well-appearing 7-month-old male infant in no apparent distress. His parents appear well hydrated. The patient appears well hydrated. His skin is Color appropriate to race and ethnicity. No evidence of rash, nevi, or birthmarks. The head is normocephalic, atraumatic with thick hair. The anterior fontanelle is open, soft, flat, with normal pulsations. His ears are clear external auditory canals. The pinnae are normal shape and contour. The tympanic membranes are pearly gray bilaterally, and there is no erythema or bulging noted. His eyes, pupils are equal, round, react to light and accommodation, and extraocular movements appear intact. No discharge, conjunctivitis, or scleral icterus noted. No ptosis, positive red reflexes bilaterally. The nose, normal pink mucosa, no discharge or blood visible, and a normal midline septum. His mouth, the mucous membranes appear moist. There is no evidence of a cleft on palpation of the palate. The neck is grossly non-swollen, negative for tracheal deviation, lymphadenopathy, goiter, or mass. The chest does demonstrate Tanner breast development 1. There is no evidence of increased work in breathing. The lungs are clear to auscultation on bilateral sides with good air movement. Heart, regular rate and rhythm, normal S1, S2 heard. The point of maximal impulse at the left mid-clavicular line at 6th intercostal space. 2+ pulses in all extremities, including strong bilateral femoral pulses, and the capillary refill is less than 2 seconds. The abdomen is soft, non-tender, non-distended. Bowel sounds are present. Liver edge palpable at 1 centimeter below costal margin, but the scratch test did reveal normal liver size of 5 centimeters. No noted splenomegaly or masses. The genitalia are the patient is circumcised, normally placed urethral meatus, bilaterally distended testes, which is a GU Tanner 1 with no hernias and no hydrocele. The extremities are warm with no evidence of clubbing, cyanosis, or edema. There are no gross deformities noted. Good skin turgor without tenting, negative Barlow and Ortolani signs. The back and spine are straight without evidence of lordosis or kyphosis, no sacral dimple or tuft of hair. Neurologic, the child is able to move all extremities symmetrically. With our first lab test, we did note that the CBC was completed and did show a large red blood cells. The diagnosis that I am giving this child is folic acid deficiency anemia. This is defined as an abnormally low level of one of the B vitamins, which results in anemia characterized by red blood cells that are large in size but fewer in number. Differential 1 would be pernicious anemia. This is defined as a deficiency in the production of red blood cells through lack of vitamin B12. This may be caused by depleted stores of vitamin B12 or due to atrophied parietal cells, which leads to a decline in the intrinsic factor, which inhibits absorption of vitamin B12. Differential 2 would be myelodysplastic syndrome. This is defined as a group of disorders that result from dysfunction of the bone marrow, which causes changes of formation or irregularly shaped red blood cells. Patients will likely present with gradual fatigue and splenomegaly. Differential 3 would be hypothyroidism. This is defined as a condition in which the thyroid gland fails to produce an adequate amount of thyroxine, or T4. In pediatric patients, the anemia is often detected before the diagnosis of the underlying disorder. Risk factors for folate deficiency anemia include inadequate dietary intake, malabsorption, increased folate requirements, dietary folate deficiency, which is rare, but it does occur in severely malnourished children, as well as occurring in infants who drink unfortified goat's milk, such as our patient. Other risk factors include celiac disease, medication-induced anemia that comes from cytotoxic as well as anticonvulsive medications. And then we also have the increased requirements due to either rapid growth, chronic hemolytic anemia, or also the increased demand from premature infants. Signs and symptoms that are typical of this particular disorder include a pallor of the skin, possible mild jaundice, the tongue may be smooth and beefy or red, the child may be irritable, and they may also be poor feeders. The guideline that I used is through the National Center of Biotechnology Information, or NCBI. This is published through the National Institute of Health, and you can access this site at the link below. Treatment of folic acid deficiency anemia is noted to be effectively treated with folic acid supplementation. Oral administration is preferred, and with our infant, we are going to be starting off with a dose of 0.1 milligram daily for infants. Education to the parent should include the following. We would need to get dietary counseling and an addition of folate fortified milk and or nutrients. And we should also let the parents know that if left untreated, this type of anemia will persist and cause glossitis, angular stomatitis, oral ulcerations, neuropsychiatric changes, insomnia, irritability, and cognitive decline. We will want to ensure that the patient's parents understand the need and urgency to start supplementation, and we should have them follow up closely with us so that we can monitor the therapy. We should probably allow 1 month check of folic acid, and then monitor when they come in for those milestone achievements to make sure that they're still meeting the neurologic demand, and monitoring for weight, height, and head circumference, and then also monitoring for any behavioral changes they may have experienced due to lack of folic acid. I want to thank you so much for letting me offer you this presentation today. I hope it has been beneficial to you, and thank you so much.